and he's going to ask one of my faculty to speak about the past, and then it dawned on me that I was the past. And then I started to get really nervous because I thought I was going to be then debating a millennial, a digital native, someone who was armed to the teeth with debating tools plucked from BuzzFeed, and who would have 1,000 or 2 Instagram friends who were ready to send in their best advice for the rebuttal. So I thought, well, maybe my role is to put up a valiant attempt and then fall on my sword, and decided that that wasn't the case at all, because in fact, it was pretty excellent, the training that we had. And I think it's important to know that, and people are going to feel sorry for us because we didn't have Google, and we didn't have internet, and we didn't have cell phones or mobile phones, but we actually had human connections, and those were pretty special. I'm going to say that we had authentic connections. We had a surgeon's lounge where you would finish rounds in the morning, you'd go in, you'd have a cup of coffee, and you would chat to your colleagues. If you had a bad night, there was someone to commiserate. If you had a sick patient, there was someone that you could say, you know, I'm really worrying about Mrs. So-and-so. And they would have a thought, or you could find someone else who did. And you got free coffee, which was pretty crappy coffee, but it was, you know, the price was good. It was a really important institution. We also had things like human beings in the X-ray department that you'd go down, we called it X-ray. You'd finish your rounds, you'd go down to the X-ray department, and you'd look at film. And you'd put up the films, and the radiologists, who remembers Bob Tuttle? Yeah. The radiologist knew every sick patient in the hospital because there were films that were coming through there all the time, and the teams of health staff would go through, and so they knew what was going on, and they had been doing this for years, so they actually had good advice for you, and they could be there when you called them with, you know, what's the best thing to do for Mrs. So-and-so. And we had a lot of camaraderie. And we had a lot of received wisdom because we worked so closely with our staff. We had journal clubs in their living rooms. We learned so much life wisdom about how to practice medicine from those. And I don't have time to share all of those, but it was a really tremendous part of it. And there was also some fun and pranks that went on, but I knew nothing about that. One of the really great strengths was the honor and respect that really imbued everything. Our chief residents were you know, Michael Taylor is probably going to miss this debate now, but Mike came back for this. We all knew who our chief residents were, and I remember Michael telling us as residents that academic half day began at 1 o'clock. We were all to be in our seats at 1 o'clock. There was no such thing as straggling in 5, 10, 15 minutes late. He didn't care where we were, it was our response. We were all there at 1 o'clock on the dot. Does that still happen? I doubt it. So, it sure didn't happen to U of T. It is only to be expected that I would wax sentimental about the good old days of 1 and 3 call, no vacation relief, which meant you worked 1 and 2, and if you had 2 colleagues who each took 2 weeks of vacation, well, too bad you did a lot of 1 and 2. And that was pretty grueling. I mean, it was, you learned that the only things you cared about were sleep and food. But it also meant that when you were on the floor, you felt supremely confident. There was nothing that happened in that hospital that you weren't aware of. You knew every nurse, you knew every patient. You didn't need to do handover rounds. You knew everything that went on. And there was that sense of, we did our first 10,000 hours in the first 2 years easily. And once you've logged your first 10,000 hours, then after that all you're doing is refining your skills. We did thousands and thousands of things so that we got them down like pat. Things as important things like daily urinary estriols. Oh, they don't do those anymore. We did.
Just stopped them last week.
We did amniocenteses blind all the time for preterm labor. We did palpation. That's right. Oh, there's a pocket there. I don't think there's any baby there. There better not be any cord. We did lots of hysterectomies. Oh my, we would do 15 hysterectomies a week easily, and a good hysterectomy was done in and out within an hour for sure, and much better if you were faster. We really learned that there's no such thing as scut work. Competency design was competency all right. It was saturation design. The idea that you can do 3 things and sign off that you're competent? No, I don't think so. You could take the easiest operator, take a DNC. You could do 100 of them, and the 101st one will stop you in your tracks. There is no such thing as a simple operation until the patient's home and well. And the
Dear, you're at 5 minutes now.
I know. I've got a smartwatch. I'm digital. There's no such thing as staff sleeping in. We had to make decisions and live with them, and your first decision was, do I call the staff? There were no guidelines, no pre-printed order sets, no one telling you how to do things. If you were smart, you'd ask the nurse. If the nurse liked you, she would tell you what the staff on call wanted you to, or expected you to do. If they didn't like you, they might tell you something that you really regretted, which is how one of my fellow residents ended up ordering a 3H enema for a patient at St. Joe's who was 8 centimeter dilated. Oh. And that enema was delivered between the baby and the placenta. Oh my, they were interesting days. Our staff, if you were in the OR, they modeled professional humility. It was always okay to ask who's operating in the next room, and can they come in and have a look to see what's going on here? I'm not quite sure what my next step is. And that was, there was no such thing as being a hero in the OR. And as residents, we were encouraged to have our own minds, and that's how Peggy Sagal, one day when she really disagreed with the instructions to do a mid-cavity forceps, asked the staff to please re-examine. The staff said, it's fine, go ahead. And she said, no, the baby's too high. He said, go ahead, put those forceps on. And she picked the forceps up, and she laid them on the floor, and she pulled off her gloves as she walked out of the room, and she lived to tell the tale. And we were expected to have the courage of our convictions. I think we had a pretty great training program.
That was excellent. So I was extra happy to be in opposition to Dr. Scattolon because she has the honor of being the first resident to have ever refuted or questioned what I did in the operating room. In fact, she repeatedly questioned and asked me what the evidence was for what I was doing in the operating room. And so it's very nice to have her as the opposition here this morning, or this afternoon. And I'm equally happy to have Dr. Blake with me. Now, I thought the way this was going to work was on an ageism basis, that Dr. Blake was going to take the side of the older physicians supporting older residency programs, and I was going to take the younger. But in any case, I wanted to tell you a few of the attributes of residency training in the past. And the first is that it was a really fun experience. Those were probably the best days of my life, and actually they were the lowest stress days of my life too. We had a lot of fun, and the residency programs and the hospitals were very accommodating. And I can speak to one example that resonated with me was to do with Dr. Francois Mowens, who some of you might know. The hospitals were so accommodating that he would bring his coveted dogs in with him on call to keep him company. Now, why he had to have his dogs with him, I am not sure. But we had seriously, we had a rich relationship with our faculty members. And I can remember one day, Denny DiPetrello suggested that we go for a picnic. And so Denny and I and one of the cervical cancer patients who had all kinds of fistulas and was not doing well, we all went down to her home on the reserve on the banks of the Grand River and had a picnic lunch. And I can also remember every Wednesday, Barry Rosen and Skip Robinson and I would skip out of the day and go play tennis over at Mohawk College. So those were indeed fun times. And we didn't need to extract these advantages through the Imperial Union. We only needed to do it through our faculty members. And one of the things that's kind of occurred to me lately is the issue of professionalism. So we're being so highly regulated, particularly in residency programs, on a professionalism basis. I have real concerns about what's going to happen in the future when residents need to pass gas, how they're going to be able to pass gas in a professional manner, and where they're going to be able to do that, and the flurry of activity as they try to get out of the room. Because I fear that the professionalism is going to constrain us severely. So as you become older, and I know there's not very many old people in the room here, but as you become older, you become more and more aware of the need to smell the roses. Appreciate things. And as residents, we truly became to appreciate sleep because we had almost none. And some of the best sleeps I've had were under the lunch table in the 4F clinic because I was so tired I couldn't stay awake. But we did develop some professionalism along the way through our role models, and I can remember the role model I had, Father Francis, Dr. Lyons. He would come in the middle of the night at 3 in the morning to do a delivery with a suit on. And to this day I remember that. Now I don't necessarily subscribe or endorse what he did. And I don't replicate his professional behavior, but certainly that was something that stuck out in my mind to this day. And I think that almost to the minute finishes our 10 minutes. Because of our rehearsals and practices.
Yeah, we're good. Hey, can I say that Steve, I'm running over time, but I was Steve's chief resident. So you get that maternal sense of pride.
So I guess it's our turn. So this is called the PowerPoint. I know that you're used to the overheads and the transparencies. We thought we would take a bit of a modern approach to our debate.
That was low.
And we're going to talk a bit about why we think that the residency training is better now. So you might be on call tonight, and so the nice thing is that you're well supported by your staff who's physically there in the hospital to help you if you need help overnight. And then after your busy night, you actually go home and you go to sleep. And that gives you an opportunity to rest and actually prepare for the ORs that are coming up in the next couple of days. So just to give you a bit of an idea, I think it's a little different than it was back in the day.
So we wanted to focus on some of the things that we think makes residency training better now. And one of the biggest things we think is access to simulation-based teaching. So that was like a long time ago, how someone might be practicing a cervical check. We don't have to actually resort to such measures. We have access to models in so many different forms. It starts off even for the medical students that have models for cervical dilatation. We move on to models that we use for the first and second year residents where they're preparing first and second degree tears. This can become a little bit more high tech and high fidelity as we move on to the boxes and where we're practicing our laparoscopic skills. So really you're able to pick up these skills in a safe environment that is not compromising patient care and improving outcomes both for your future patients as well as how confident you are actually with your skill set. We have access to the Center for Minimally, the CMAS Center and the CMAS labs where we get to do laparoscopic surgery on pigs. Dr. Bates actually helps with this and knows how wonderful it is. And we learn a lot from this.
Putting me in a conflict.
I am actually going to put you in a conflict of interest. And so all of these things are actually allowing us to learn these skills without just practicing and gone are the days of the see one, do one, teach one. You should actually be doing a lot of them in a safe environment so that you're competent when you go and do them on patients.
So we also wanted to bring to everyone's attention the difference in evaluation and evaluative-based learning. So, you know, we pride ourselves on trying to provide feedback to the residents so that they can improve on their skills. It's an opportunity for them to identify what could be done differently, what could be done better, so that they can get to be stronger and advance their skill sets as well. So often we do these evaluations in real time, so they're done in multiple settings. It could be in the operating room, on labor delivery, in the clinic, many different opportunities to provide residents with this very valuable evaluation. And it's also allowing us to shift somewhat towards the CBD, or the competency-based design, or competence by design. So that's the next step in the evolution of our training, where it's not going to be a finite number of years where you put in your 5 years and you're qualified. It's based on your acquisition of skills and your ability to successfully meet the requirements of the training. So now I'm not trying to imply that evaluations were provided in a negative way in the past, where things were violent, but I think that, you know, in the past people might agree that there was some, you know, verbal altercations if you didn't do what you were wanted to do by the staff person. So we've definitely shifted away for a more inclusive and safe environment for learning and providing feedback.
And then we move on to the environment that we're training in now that does actually protect us in ways, especially because of payroll and the existence of reduced duty hours. This is just going to lead to more well-rounded residents who have a life outside of the hospital, who don't fall asleep under the table of the 4F clinic, and allows us to actually be more well-rounded and actually provide better patient care. We have families, we have hobbies, we stay fit. And a lot of people will argue that these reduced work hours are leading to less experience. There's good studies. I used PubMed last night to do a bit of a search that has showed that it hasn't actually, in training in obstetrics gynecology, it hasn't made a difference in the surgical exposure. And the amount of ambulatory experience. I think a lot of the reduced hours have actually led to you not having to do as much of the other work that doesn't always actually contribute to your learning. I'm sure there'll be a rebuttal for that, and there can be. And there's also improved patient safety outcomes. There is a journal article that was published just recently in Perinatology Journal that showed actually a difference in mortality since the implementation, in patients, since the implementation of reduced duty hours.
So access to information has definitely changed over the years. So gone are the days where you get your kerosene-filled lantern and you have to walk 3 miles in the snow, uphill both ways, making your way to the library where you go through the periodicals or microfiche, whatever these things are called. Is that a thing? To get that, you know, that coveted book with that one study that you need to provide, you know, insight as to what to do for your patient. Now we have something far better. We have, oh, Dr. Google? No, that's not what I meant. We have a lot of amazing resources that are evidence-based, that are at our fingertips, that allow us to provide access to evidence-based medicine, which ultimately allow us to provide the best available care and apply this information to our patients. So we have this at our fingertips on our phones. And I do think that being able to access information so much more readily does take away a lot of the time that was used for doing these research. It does provide us with more availability to access the information and then do what we need to do for our patients. So you're spending more time with your patients, you're spending more time in the OR because you're not needing to spend as much time, you know, in the library looking for that one book that somebody else might have thrown, you know, out the window because there was a bit of competition we hear back in the day when resources were scant.
And we just wanted to talk that we really feel feel that we have very diverse and wonderful training opportunities for all residents. We go through all the subspecialties. We have great exposure and great mentors that are teaching us. We have lots of exposure to various sites and preceptors. What's become much more, I think, prevalent in training today is we get out there and we get to all the different sites. Gone are the days where I think you spend more time just at one location. We're getting out into the communities and we're seeing what training is available in all these places.
So I think that's all we have, and we welcome any rebuttal that our opponents might have, but it might be a little difficult.
That was our last call together. One of us was the intern and one of us was the resident.
Yeah.
Residency.
And the nurses brought the
We did not wear that
things
too.
for us. Thank you.
We have 3 to 5 minutes for rebuttal.
Okay, so I'll
Please go ahead.
Well, I was really nervous that the residents would have something, some surprising to toss at us, but really,
That is weak.
up to date, that's kind of like a Reader's Digest of evidence-based medicine. Surely you would go back and look at some primary source material and make your own Cochrane analysis of what's going on. And of course, we trained with Dave Sackett and Murray Ankin, so we were not novices to evidence-based medicine. Hiding books, you must be a U of T grad, that did not happen. Reduced duty hours leads to decreased risk. Well, increased handovers increases risk, and the jury is out as to whether or not it's actually safer for patients. Good arguments that actually the patients were better off when there was few people on call, working longer and harder. Simulation, well, we had simulations. We had little rings on labor and delivery to practice your summaries or dilator. When you went to learn how to put in chest tubes, you'd push against the surgeon and then leave the pressure off until he knew you weren't going to keep on going right through the patient. So, we did our simulations, but we really didn't need them because we did so much work that we actually didn't need the fake stuff. Well supported by staff in-house. Honestly, we didn't need babysitting. Evaluation, you've got all these fancy methods of evaluation. We heard it real time. Stop. That's no good. Cut there. And none of us got our feelings hurt. We just took it like real strong people, learned our lesson, and did better the next time. No one needed to pussyfoot around us, and we got even when it was time for the annual yacht party, when we could really skewer our faculty. And work-life balance, well, you're using it like it's a noun, and if you're in balance, you're not moving, you're standing still, and that is dead boring. Work-life balance is a verb, and once you learn how to balance and keep balancing, you'll find that life is dynamic and fun, and you're always on the move. Woo!
I'm glad you're on my team. You are strong. But although a low IQ is attributed to the older gynecologist, I would like to remind my 2 esteemed opponents that there are some tenets of simulation. And 2 of the requirements of simulations are that there be high fidelity and transferability. And I would contend, on a very serious level, that non-laparoscopic simulations may not meet that requirement, may not. And if any of you have ever worked on a beef tongue that's been submerged in brine for 24 hours and then tried to suture on it as a simulation, what'd you call it, fake? Yeah,
Fake
news. As a fake practice model, you'll know that it's a very disappointing experience. The beef tongue is nothing like the human perineum, and it defies or fails to meet the most basic requirements for simulation. And so I would contend that the non-laparoscopic simulation models are indeed a great disappointment.
Okay.
questions about laparoscopic simulations since I
No,
had
you
the
don't.
program. That's what 5 minutes.
Rebuttal.
I just want to ask for the beef tongue. I don't think anybody was talking about beef tongue a minute ago. The one of the things
Hey,
that
Donna can support me.
Well, we haven't used beef tongue in years.
yes, that wasn't part of our training, so your memory might be failing you a little bit at this moment. One of the things that, you know, these no pre-printed orders, you wrote the orders and you asked the nurses what they thought you should order for the patients and what the staff would want. I can't see how that would be a good idea at all. We know that standardization is the hallmark of safety, so just kind of trying to remember what they want or checking with your nursing colleagues who are wonderful colleagues, but I'm not sure if that would fly in a court of law when why the patient received, 5 milligrams of, IV Dilaudid or something like that. Anyways, safety. I'm not sure that people would, prefer to have been managed in-house by the residents who kind of are just winging it, figuring it out as they go back then, than being looked after by a multidisciplinary team these days.
We did decide that we have no rebuttal for the passing boss comment because we're not sure what that's about.
And I think that's all we need to say because it's pretty obvious.
Now we have the opportunity for people to ask questions or point out flaws in their argument or whatever. So chime in.
We need some help here, guys.
Yeah, help these guys.
I think we're a little outnumbered.
Dr. Comer.
So, evidence-based medicine was clinical trials plus your experience.
You'll have to talk a little louder, Larry.
So, evidence-based medicine was clinical trials plus your experience. We had a hell of a lot more experience. You're forgetting half of what evidence-based medicine is.
But I think it's not just experience, but the experience has to be collated into well-formed trials that can give you statistically significant information as opposed to just anecdotal. So I do agree that experience is definitely important, but you need that other piece to have it in a systematic way to, I think, extract the information from it.
But if I could rebut to that, those trials tell you exactly what to do for 2,000 patients or 20,000 patients. They sure don't tell you what to do for the patient who's in front of you. And if you look at how those trials are constructed, they probably check out 60 people for every one that they accept because they're looking to just reduce it to the pure single question. And patients don't come like that. They come with a lot of complexity. And the only thing that's going to help you with that one-on-one decision-making is
Experience.
Experience. Oh, Dr. Fedorko.
Thank you all for great arguments. And I mean, I've got to lean closer to one side based on my age. And to the young'uns, the preset orders, the computers, the EMRs, all of those sound really very good until technology fails. And it does fail. And suddenly you've got to write your own orders. And if you've never actually written them, you've just run down your little checklist and signed your name at the bottom, you could be in big trouble because you're not going to remember the dose. You're not going to remember every step on those orders. Whereas if you're used to writing them out, then you write them out. Similarly, Dovetail at St. Joe's, St. Joe's. We've got EMRs, some work better than others. And it still goes down, and we get an announcement over the loudspeaker at St. Joe's, go to traditional methods of documentation. And that's so I challenge you that their new technologies are not flawless, and they can lead to some difficulties.
Sure, but old technologies where someone's using a pen and paper and it's illegible and no one can make sense of the dose or what that person has written is kind of useless too.
okay, so rebuttal, if you talk to any malpractice lawyer, they would prefer to defend an illegible handwritten record than an EMR constructed from drop-down menu.
Just to add to that, I agree that there are flaws to the newer systems, but just because something might have flaws doesn't mean it shouldn't be adopted and we shouldn't move forward. So there's flaws with other things we've done in advancements. So for example, going from an open surgery to a laparoscopic surgery, our equipment might fail. It doesn't mean we should therefore abandon the prospect of moving forward and advancing our skills or moving to something that potentially could be better.
But you were citing it as one of the advantages, so I was just challenging you on that.
That's fair.
Any other thoughts or comments? Come on, you gotta be brutal with these people. So, I think we've come to full circle.
Can I just say something? I do.
Yeah.
I just want to say that I'm forever grateful that I trained at McMaster, and I hope that the graduates who train today feel that same intense sense of gratitude. I'm forever grateful to the faculty who trained me, and it was mostly training and a little bit of education, but maybe a bit of a balance. We were responsible for our education. I really want to, Corinne Devlin's not here today. I'm sure we all have a special bond to our program directors, and I thank you for giving me the chance to say how grateful I am and how much that training I had is still in me, how much I remember the specific patients, I remember the words of the faculty, and I remember a philosophy that was patient-centered and respectful and was based on sexual, human, reproductive health rights long before that language was current. And I hope that training today is as rich and meaningful to the residents of today as ours was. And I want to say that, to follow my sword a bit and say, the training of today is preparing residents for the world that they're moving into. Our training environment wouldn't have, and training has to move along.
Thank you very much. That's a great summary. Any further comments from the junior faculty?
Some of it echoes what Dr. Blake had just said. At the end of the day, we are a reflection of our teachers, and our teachers were trained in the system that we were kind of jokingly criticizing, so somewhat jokingly. But it really is the truth that, we are the physicians we are because of the teachers that we've had and the mentors that we've had, and many of which who are in the room. So we are also quite grateful for those opportunities and those experiences.
Thank you very much. This has been a great opportunity. I had no idea that, the people up on the stage would look like Madonna with these little microscopes.
The dance number's coming up.
With the exception of Dr. Bates, he doesn't look like Madonna at all. But this has been a great opportunity to debate this very important issue, and we're not quite sure how we would do this, but I think what we can do is do it by applause. So for the first group, be it resolved that residency training was better in the past, can we have a show of hands?
I thought we were going
And
to do it by
applause. Show of hands. It's not fair to clap in front of the microphone. Now, for those who feel that the training is better presently,
I think you have a partisan crowd.
Yes, I think
I think the age gap is a little bit evident.
I think the young people are doing something else with their Saturday.
Yeah, that's because those people have work-life balance. They've decided that this isn't part of that. Anyway, I think really, in realistic terms, we both heard great presentations, and they both presented well, and they both deserve an award for winning a great debate. Thank you very much. Now, I just have to get my paper.
The question should have been, when would you have rather been a resident?
Yes. Yes.
I think it was less stressful for us.
So is the slideshow ready to come up for? So we wanted to put up at least a slide for to recognize the deceased members of the department, to show respect to those